Hi. Um, Hello. My name is Nina Rescic. I come from Josef Stefan Institute, which is in Ljubljana, Slovenia. I'm really happy to be here to talk, to listen to presentations in the morning, in the afternoon. I'm currently a PhD candidate or PhD student. I have a background in applied mathematics, and now I'm converted to the artificial intelligence in health domain. So this day has been very interesting for me from both part of this. Okay, so I'm here to talk about the SmartCHANGE project, which is a AI-based long-term health risk evaluation for driving behavior change strategies in children and youth. Um, hmm? Okay. Ah, okay. So there has been a question raised about the number of authors of the paper that I'm presenting. So the paper is actually kind of a publication based on the proposals that we wrote for this project, which is the Horizon Europe Research and Innovation Project that has just started. So we're currently in the month 3 of it. And there is 13 international multidisciplinary partners involved. So as it was mentioned before, there are people that were involved somehow into putting together the project, kind of co-authored the paper as well. So there is another reason for the number of authors, which is the whole structure of the project, which I will kind of talk you through, and I think it will be understandable afterwards. Yeah, so introduction and the background for this project, for this. So the main objective is to develop an AI-driven decision support tools to reduce the long-term risk of non-communicable chronic diseases in children and in youth. So the NCDs, the non-communicable diseases, are bad. Okay, so I think we can agree on this. And there are, besides, of course, being bad for the person in question, there are also problematic for public health in developed or undeveloped countries, due to the common risk factors, which are obesity, low physical fitness, unhealthy lifestyle habits, and so on. What is the thing, or the idea is that a lot of these risk factors, the above mentioned risk factors, actually start in youth. So both from psychological or changes or physiological changes, or from either bad habits. So the idea for this project was to address this target population, to put emphasis on the population on children and on youth, because here is an option to try to see who is in risk of developing one of these diseases, and if possible, maybe prevent or at least slow down the development. Something about the background on why did we decide, or why is the project focused on this. So the existing tools are primarily, there are some existing risk tools, and they are primarily focused on adults, which can lead to missed opportunities for the risk detection in youth. While recognizing youth with such a risk may seem quite easy, maybe some of you thought, oh yeah, of course, I can think of somebody who might have this risk. We have searched the literature and found that only, for instance, 35% of doctors in the UK are aware of recommendations on physical activities, and only 13% of them can state them. And one, maybe even more important statistics is that about 80% of parents that have insufficiently active children think that their children is actually active enough, which might be a problem. So, as mentioned, the risk prediction tools for children are missing, and those that are developed for adults are not much used. So we asked ourselves a question: how can we make our tool actually used? So we thought through different technical and aspects, and I will walk you through it. If in the end we can discuss. So here is just a bit of a sketch of how SmartCHANGE will be connecting different areas, from children, from medical professionals, from families involved with children, from schools, and so on. Let me first talk about this more technical part, the methodology which will be used. So we have gathered or have gathered yet the information about 15 data sets. Some of them are publicly available. Some of these data sets are already been collected by some of the partners involved in the project and so on. So this is a very, very big number of data. However, some of these data sets are, of course, different from the others. Some of them maybe contain information about the fitness, some of them contain information about the diseases or some biomarkers and so on. So this large amount of data will have to be somehow cleaned and unified, which is kind of the task of one of our partners, so the organizers actually of this special session. So the idea is to have this data cleaning kind of on two levels, or on two steps. The first, to clean the data, which means eliminate the irrelevant data, ensure the data is consistent, improve the quality. And then on this harmonization level, which will make sure that the data has a meaning that is understood by people working with it or by the systems, and to have to put it in a format that it's easy to be transported or communicated about. Okay, so maybe an example of data set, so you will see what I'm talking about. The first one that maybe I will talk about more here is the SLOFIT data set. This is a data set that is collected in Slovenia. What's really interesting about this data set that it's collected nationwide. So this is kind of a national testing system that it's done each year, from the first year of primary school to the final year of secondary school, which means about 12 years. We have all been involved in this, myself included when I was in school, and it's still going on. And these data have some information about the age, the BMI, the fitness, and some other stuff. Next, we have a data set that has, so you can see in the first data set that for one subject you have many many instances based on the age as they aged, as the subject aged. In the second data set, we have data that it's also including BMI and fitness, but is also including, for instance, cholesterol. However, the age of the instances here, it's in the adulthood, not in the child era anymore. And maybe then there is the third data set that actually has the information about the disease, but doesn't have the information about the BMI or the fitness, but has the information about cholesterol. So what we have here. Idea is for this first baseline models is to start. So keep in mind that this is just a description of one way of building these models. It's not the exact way. It has not been implemented just yet, but this is a starting point that we will follow because it has proven in the past that it is working. So the first model, for instance, is based on the first data set that I was showing. And from this model, we can somehow predict the adult fitness or the adult BMI from the child fitness. So as shown, each instance, for each subject, there are several instances based on through the years of their schooling. So it's kind of possible to predict where it will go later in life. The second data set that was shown, for instance, allows us to predict cholesterol based on the fitness and the BMI from but for the adults only. And the third one is the last data set that actually has the information about these non-communicable diseases. Predicts disease from adult fitness, BMI, and cholesterol. But this data set, for instance, doesn't have information about adult cholesterol or adult BMI and adult fitness. So once the data is fed from these data sets to different models, from the first model, we can get the information, for instance, about the adult fitness and the BMI, and from second one, the adult cholesterol. And this is then fit into the third model, which kind of allows us to see for children currently being children, what will happen with them when they're in their adult or elderly age. Then there is a more complex model planned, which will not be built from this different chain of models, but will be a unified model, probably based on neural networks, which is kind of allows us to even feed the data on different levels of the model, not to feed them all at the same time in the beginning, but in some timely manner. Yes. Another thing that will be considered here is, of course, the privacy. So, as mentioned, we will be working with youth and children, and this is sensitive data. This is considered sensitive data, which cannot be just sent around and do with this data whatever you want to. But we would like to make sure that even though the data is kept private, we still have a way of learning from them. So here we will learn this, use this federated learning approach, which has been mentioned before in the first presentation, which kind of allows us to train the models locally and then just send out the information about the model, not the actual data to this central position, but just the model. So what do we know about, what have you learned about the data, but not the data. Okay, so this is more of a technical aspect. However, if we want to use this in practice, we also had to consider the implementation of it all. So the first thing that it's to be mentioned is this participatory design and co-creation. So this project will target on two target groups. The first are the health professionals, because they are actually involved with this disease aspect. And the second stakeholder group will be the youth or families in case of when the children are younger than 10 years. So there will be two development cycles. Kind of the first one will have this interactive prototype with a feedback, afterwards the software development, and when the feedback gets back from the pilot sites, the changes will be made to the existing softwares. There will be also some participatory design meetings being involved, where different either experts will give their opinion on what should be implemented, either the families will have another feedback on what should be involved or not. Yeah, so for instance, I would just like to show maybe a kind of a mock-up of a implementation meant for health professionals. So have in mind you are a health professional, you have in front of you a person that you would like to assess the risk of developing these non-communicable diseases. You have some information about the data, the sleep, the exercise, and you would like, for instance, know what's the risk for developing cardiovascular disease at age of 65. You will then maybe have more, would like to know more details about the exercise. You will see, okay, this person is having 13 minutes of vigorous exercise per week and 60 minutes of moderate exercise per week. Okay, this puts him in the baseline of this risk somewhere close to be more risky than the others. And then you would then, as a health professional, you could then simulate, okay, what would happen if this person would be maybe instead of 30 minutes exercise of vigorous exercise, be doing 60 minutes of vigorous exercise. And then you would have the simulation somewhere on the side. The next thing is the application for citizens. This will be built in the mind of youth or families. And the idea is to have some kind of a healthometer, to put it like that. And this healthometer would, for instance, I would be using this application, would tell me, okay, so on this healthometer, you're somewhere in this orange red area, so it means you have to improve, and what to do then. And for instance, if I choose to go for a hike, then the healthometer could somehow, after some time, recalculate things and say, okay, but if you go for a hike maybe every day, you increase or decrease the risk of developing these chronic diseases for some amount. How much, it's hard to say standing here. Okay, so the evaluation will of course be a very important part, because otherwise it doesn't really make sense to develop such tools. The evaluation will be done in 4 countries. There will be a pilot site in Portugal. Children from 6 to 10 will be involved there. There will be a pilot site in Slovenia. The same group of children will be somehow involved. Somewhere maybe in the Portugal, for instance, more of healthcare professionals will be involved. In Slovenia, it will be more based maybe on schools and exercise specialists, because as I, for instance, mentioned that project, that slow feed data, this is already being used currently. Then in Finland, it will be focused on a bit older group of children, and on Netherlands as well. So as mentioned, this project is in the beginning. It's month 3 of it. However, many of the things that I've talked about, especially in this technical part, are already being used in some other areas, in some other projects. And the whole idea is to bring all of this together to make something big and something important, we believe, for the future of the children, the youth, and everybody. So with this, I would conclude my presentation. And if you have any questions, I will try to answer. If you have any doubts, I will try to make them clearer. So yeah, thank you.